Welcome back to another installment of Dry Eye Fireside Chat. I'm Dr. Damon Dierker coming to you from Indianapolis. Pleased to be joined by my colleague, Dr. Mark Eltis. He's practicing in Toronto as an optometrist. He is president of College of Optometrists of Ontario and the Canadian ambassador to the American Board of Optometry. Mark, welcome to our Fireside Chat.
Thank you so much. It's a pleasure to be here.
So we have a lot of similarities, been in practice for a couple of decades, have passions for both ocular surface disease and glaucoma. And obviously we have a lot of patients that have both of these conditions that we need to manage. And I know recently you presented a lecture or presentation on the dry eye and glaucoma nexus, this connection. How are dry eye and glaucoma connected? I know that's a big topic, but what are some of the most important ways that you see in treating patients with both conditions? How are those two conditions related?
Sure. One major realization I had was that glaucoma patients, we have a lot of treatments and everybody knows from drops to surgery to other things, but they don't usually go blind because of a lack of treatment. A lot of patients lose vision because they're not taking their medications. Why? It's because of the ocular surface disease and the dry eye, which makes them stop doing what we're telling them to do because they don't feel the glaucoma and they don't know it's actually hurting them, before it's too late. But when they put in the drops, they get that sting or they get that burn or they know their eyes aren't feeling as well as they used to, or people are saying, why are your eyes so red? So that's one of the major realizations I had. Another connection I see is that the trend towards healthier living impacts both these conditions and a lot of things that we'd take for granted or things that we didn't know could help. So a lot of patients would come in saying, what do I do for glaucoma? And I could say, well, this is all we have. And they say, could I change my lifestyle? Can I change my diet? Can I change the way I do, all these things? And I couldn't say there was actually any research to prove it, but now there is emerging research. And that was actually the goal of my talk. And it's based on a lot of the articles I've published with the Optometric Glaucoma Society. And it talks about the latest research that healthy eating can make an impact in both glaucoma, and we know in dry eye can help. Exercise can be very helpful. Meditation, yoga, your sleep position, the amount of sleep, depression and anxiety, which we know is a big factor in dry eye, can actually be an impactful factor in glaucoma. There's actually research showing that people who are anxious have an increased risk of glaucoma, and potentially people who are depressed. So it's not that they're depressed or anxious because of the glaucoma diagnosis or risk. It's actually that their condition, anxiety and depression, could be increasing their risk of converting from a suspect to a glaucoma patient.
Yes, I think everything that you've mentioned is some of those clearly go together. And then I think about how I approach these different conditions, and really everything that you said totally aligns with things, but I don't always make the connection between the two and how I can maybe do a better job of counseling patients by having the same approach for both conditions for a lot of things, especially when we're talking about a more holistic approach. When we think about the glaucoma patients in particular and preservatives and drops, and we know that if we have a glaucoma patient and we're treating them with, kind of historical measures, we're probably going to have a dry eye patient at some point. When we look at somebody that has glaucoma already, does that actually worsen if they have dry eye? If one of my dry eye patients converts to glaucoma, are they more likely to get worse quicker?
Well, it's an interesting question. Of course, a lot of times when I talk about these topics, and even in my presentations, I say we don't have definitive answers yet, but there is research which gives us snapshots into what could be the reality. So there was one recent research paper about how IOP can be lower in the summer and higher in the winter. And it was actually, summer seemed to be protective. And one of the reasons that was theorized is because of potential dry eye being worse in the winter, increasing IOP. Now, we don't know the exact mechanism. There could be other factors, but it's just showing that there is a connection, and it's possible that dry eye sufferers can get worse. And of course, also because they may not take their medications as much, because we know that even aside from the preservatives, there's evidence that the actual glaucoma medication may worsen dry eye on its own. So obviously, with that being the case, there's a potential for non-adherence to the treatment.
I'm definitely going to have to pay attention to that. You know, I grew up in Minnesota. I'm used to the harsh winters. Indiana is a little bit more mild, but I will make sure that I'm keeping a keen eye on IOP increases that maybe I couldn't explain before, and it's probably because some dry eye issues and lack of compliance, especially when we have the colder air come in. So a lot of research into these big topics. If you think about a couple of takeaways from our colleagues in terms of things that you have changed in your clinical practice for either patient education or specific management, what are a couple big takeaways for our fireside chat aficionados here that they can take home to their practice?
Sure. Well, I think the most important thing is don't wait until it's too late. So I treat dry eye aggressively, even when I see a little bit and patients aren't complaining. The same way I do a lot of diagnostic tests for glaucoma suspects. And it's true that 90 to 95% of the patients that I treat as suspects, I try to do the diagnostic testing for them, they're not going to get glaucoma. And I explain that to them very clearly. But for that small percentage, that 1 to 5%, they could go blind if we don't do the preemptive diagnostics. So in that same kind of line of thinking, I want to treat dry eye aggressively, or at least diagnose it and tell the patients so they're aware of it, because some of these patients may be glaucoma suspects, many are, or some may develop glaucoma. So we don't want to wait until the dry eye is something which could impact their treatment. So I always like to educate patients on all their options. I'm not the type to tell them you have to do this or you have to do that, but I like to give them the opportunity to do it if they're ready to do so. And I think that's the connection, the nexus between dry and glaucoma, that don't wait till there's actual signs that the patient can see or feel, which is too late in both. There can be chronic damage in dry, of course, as you know. So when you see the signs, educate the patient and then work with them for a tailored approach to both glaucoma and dry eye.
I think that's great. I mean, a proactive approach to management. And I think with this in mind is we still really need a proactive approach at screening for patients. We're taught in school and our careers, we screen ad nauseum for glaucoma. When you have 10 to 20 times as many people having dry eye, we should be doing at least that much for our potential dry eye patients as well. So a lot of great pearls, Mark. There's some things I'm going to implement, especially looking at seasonal variability in IOP and some things with diet in terms of both glaucoma and dry eye. I thank you so much for your expertise, and thanks for joining us on Fireside Chat.
Thank you so much. It's been a pleasure.